Staging of C rectum. The standard clinico-pathological staging is the best indicator of prognosis for patients with the rectal cancer. For rectal cancer, increasingly common to use clinical staging as the basis of decision to initiate neoadjuvant chemoradiation therapy. Therefore, accuracy of the initial staging is critically important both for the management and prognosis. And there have been numerous studies that have been elucidated the prognostic marker, including pathological, socioeconomic, and molecular markers. However, there is enough of the to appear the prognostic value, and then that commonly used to define management, and this is related to the large number of tests that could be used as a lack of standardization of this test, and the molecular marker that has been emerged as the most important interest in the decision making is 18q of 18q. This marker is fully reviewed elsewhere, and the staging system should be used to evaluate the patient with the rectal cancer is AJCC. TNM staging has been recently revised to categorize the patients with stage 3 node positive tumors, and Duke staging system has been used many years to provide the less information of the TL and the TNM and should not be used. Therefore, gradual change in the TNM system that primarily reflects the staging grouping rather than the system itself, and therefore the other system should be acknowledged for the historical interest. So patients now often have both the clinical, that is preoperative staging, which may define the need for neoadjuvant therapy, and the pathological postoperative staging. And the initial therapy with the chemoradiation produce substantial downstaging. Approximately 15% of the patients will have a pathological complete response. So this is important that around 15% of the patients will have pathological downstaging PAT-CR in case of rectal cancer in post neoadjuvant chemoradiation, and as many as 40% those with the favorable tumors. Although, so if there is favorable tumor, there will be 40% PAT-CR, and in case of rectum, there is approximately 15% of the PAT-CR. Although some believe that the degree of response to neoadjuvant therapy should alter subsequent treatment, and this is in fact that the area of active investigation. The current standard of care dictates that all surgical planning and adjuvant therapy be determined based on the initial clinical stage regardless of the tumor response, and the guide is based on the part of the either the good tumor response locally to chemoradiation does not translate into a reduced risk of micrometastasis, and thus does not lessen the need for adjuvant postoperative chemotherapy. So with this will continue to be in the face of the new data, more aggressive neoadjuvant regimen remains to be seen. So numerous studies have indicated that tumor response to neoadjuvant therapy is an important predictor of multiple oncological endpoints for patients completing the full course of multimodality therapy. Patients with PAT-CR in a particular demonstrate excellent long-term results with the local recurrence rate as low as 0.7% and significantly improved DFS and OS compared to non-responders at 5 years. So it is unclear this whether a favorable outcome can be maintained should be course of treatment be altered based on the post-operative reassessment. Although it is not standard practice to alter treatment based on the local response to neoadjuvant therapy, preoperative staging prior to surgery may still be valued not only as a prognostic predictor. So preoperative staging is a prognostic predictor, but also for detecting interval metastatic progression. Multiple study found that CEA serum carcinoembryonic antigen levels, for example, between chemoradiation therapy and surgery, as this value as well as the pre and post treatment ratio that may be more important in predicting survival than initial measurements. And in addition, some studies as they advocate restaging with the chest abdomen CT, as this changed management in 12% of the patients and spared 8% undergoing non-curative rectal surgery due to new finding of progressive metastatic disease. So the best restaging strategy for assessing complete response is another focus of ongoing debate. And in one recent prospective study, underwent clinical assessment by DRE, endoscopy with or without biopsy, T2 weighted MRI, and diffusion weighted MRI, the single most accurate modality found to be clinical assessment with addition of MRI and diffusion weighted imaging, further improving diagnostic performance, 98% probability of predicting complete response. And the authors recommend a combination of all these factors as the optimal strategy for assessment. And major change that has occurred in the new version of the staging system is acknowledgement of the both T and the N stage have an independent prognostic importance for local control, DFS and OS. And thus the for patients with N0, N1 tumors viewed separately, the extent of primary tumor in the rectum is of additional prognostic importance. Patients with T1, T2, N1, they have favorable prognosis and outcome superior to the patient with stage 3, and patients with T3, N0, M0 stage 2 have an outcome slightly inferior to that with T1, T2, N1, demonstrating independent prognostic importance of the T stage. So although at one level staging is straightforward, the actuality of proper staging is much more difficult, as it relies on multiple quality control issues that can be mislead the clinician regarding the proper therapy. It has been well demonstrated that for patients with colon and rectal cancer who are pathologically N0, prognosis is markedly improved for those with 12 or 14 nodes were identified by the pathologists as compared to fewer nodes were identified. And this could be a surgical issue or a pathologist issue, but it suggests that many patients were inappropriately understaged, and which could result in a inappropriate therapy. And others have shown that staging accuracy continues to improve as the pathologists recover more nodes, with leveling of at least 12 to 20 nodes recovered. So in rectal cancer, however, end stage presents a particular challenge. There are often fewer lymph nodes in the specimen, and preoperative radiotherapy is thought to reduce the number even further. One recent report suggests that lymph node less than 12 in a pre-treated specimen may be a marker of high tumor response and improved rather than a compromised oncological outcome. So in the study of 237 patients, local recurrence rate was significantly higher when lymph nodes of more than 12 group as compared to those with inadequate lymph node retrieval. And as with colon cancer, the percentage of positive node is likely to be greater prognostic importance than total lymph nodes removed. So in a recent SEER data supporting the concept that for stage 3 patients, an increasing number of positive nodes and lymph node ratio of more than 0.5, that is an independent negative predictor of survival, whereas total number of lymph node had no prognostic impact. So how many numbers of node retrieved versus how many number of nodes came positive, and ratio if it is more than 0.5, that is an independent negative prognostic predictor of survival. And one author found the optimum staging was achieved with the retrieval of 16 nodes in patients treated with neoadjuvant therapy and 18 nodes for those undergoing upfront resection. The same issue for the T stage determination, and if the pathologist does not look carefully for evidence of the extension of the tumor through muscularis propria, patient can be understaged, resulting in inappropriate treatment. Close or positive circumferential margins are a poor prognostic factor, which can only be found if the pathologist assiduously evaluates the radial margin. And the standard staging procedure for rectal cancer entails history, physical examination, complete blood count, liver and renal function, CEA evaluation. Routine laboratory studies are quite insensitive to the presence of metastatic disease, but they are usually ordered as a screen of organ function prior to surgery or chemoradiation therapy. High CA levels are associated with the poor survival. and give an indication as to whether follow-up CA determines are likely to be useful. For rectal cancer, examination is experienced by the examiner is an essential part of the pre-therapy evaluation in determining distance of the tumor from the anal verge or from the dentate line, involvement of the tumor from the anal verge or from the dentate line, and involvement of the anal sphincter, amount of circumferential involvement, clinical fixation, sphincter tone, and has been replaced by imaging studies or endoscopy. In colonoscopy, to evaluate the remainder of the large bowel is essential if the patient is not obstructed, to rule out synchronous tumor or presence of polyposis syndrome. And local staging is completed by US or MRI